This conference will now be recorded.
So today we are going to discuss this epilepsy talk, that is management of pregnant women with epilepsy. It is a 2017 October talk. This is important because it is almost a summary of your guideline, epilepsy GTG. Only thing I will tell you one caution here. Whenever you are getting any discrepancies in the percentages or numbers, please follow GTG and do not follow the talk. Okay. Even with any recommendations, if you get any discrepancy between the GTG and talk, you have to follow the GTG and not talk, because the talk is individual author's review. Okay, so that you have to keep in your mind that you have to follow the GTG. Okay. So epilepsy affects 0.5 to 1% of women of childbearing age, and it is the most common serious neurological disorder in pregnancy. Antiepileptic drugs, it is the mainstay of treatment for epilepsy, and usually one out of every 200 pregnant women receives antiepileptic drugs. Almost two-thirds of the women of epilepsy, they will remain stable throughout the pregnancy, and 96% will deliver a healthy baby. So this is a good figure. The risk of mortality for pregnant women with epilepsy is 10 times higher than that of general population. Okay. And maternal mortality rate for pregnant women who are on antiepileptic drug is 60 per thousand. 60 per lakh. Okay, 60 per 1 lakh. Now, so for this epilepsy, they have divided this talk into, basically in this talk, the major information is given on the antiepileptic drugs and its effects on the pregnancy and the fetus. So, and they have also given regarding the management of epilepsy in the pregnancy. So, regarding preconception care, it is very important that women should receive preconceptual counseling as a routine practice. Okay, and they should also be informed about epilepsy and non-epilepsy related outcomes of the both mother and the baby. Interdisciplinary communication. That means multidisciplinary approach is required between neurologists, physicians, general practitioners, and obstetricians. As up to half of the pregnancies, they are unplanned. So this discussion should be done with every woman of childbearing age. Every woman of childbearing age who have this epilepsy, instead of preconceptional counseling, this thing should be a part of the routine discussion with the neurologist, okay, or their epilepsy doctor. So what are the discussions that should be done at preconceptional counseling? So women should be informed that 96% of pregnancy, they have a good outcome. The women who have been seizure free for more than 12 months or more than 1 year, they're likely to remain seizure free if they are compliant with the treatment. So during the pregnancy, they will be seizure free if they are seizure free for more than 1 year. But they should be compliant with the treatment. Most women with epilepsy can aim for vaginal birth unless there is obstetric issues. So epilepsy is not an indication for either cesarean section or no for induction of labor. And always, if they get pregnant, whenever they get pregnant, it is better to register the pregnancy on the National Epilepsy and Pregnancy Database. So these are the things that you should tell with the woman in the preconceptional counseling. Now, how to optimize her health in preconceptional period. So you have to advise her regarding remain compliant with this antiepileptic medications, close contact with neurology team for adjustment of the drug dosage, avoid any seizure triggers, aim to manage seizure effectively with lowest dose of antiepileptic drug, so that it will have a very minimal effect on the fetus and her pregnancy also. Aim for low dose monotherapy drug. Avoid changing medication if the woman is seizure free on that medication, unless on the advice of neurologist and after close discussion with the patient. So if the patient is stable on that medication, better to not to change that medication. But it is also important that if she is receiving any teratogenic medications, better to change that medication well before her pregnancy, so that she will be adjusted to that medicine. So consider changing to less teratogenic antiepileptic drugs wherever possible. And now, what are these less teratogenic antiepileptic drugs are? So there are three options. One is lamotrigine, levetiracetam, and carbamazepine. Avoid sodium valproate if other ADs are appropriate. Note the optimal serum concentration pre-conceptually. Now here RCOG differs here. So RCOG doesn't recommend any drug monitoring, okay, drug level monitoring of this antiepileptic drug. Optimize health conceptually. That means optimize and BMI, reduction of alcohol consumption and regular exercise. Stop smoking. It is advised for all women in the her preconceptional counseling, and start 5 mg of 5 milligram of folic acid several months preconception. This is a very repeated patient, so you have to start her not on 400 but 5 milligram of folic acid several months preconception. Now, what is the effect of pregnancy on epilepsy? Now, be aware of these percentages. These are very important. So, people, 64% women remain seizure free. 70% will have increase in the seizure frequency. 16% will have decrease in the seizure frequency. Intrapartum seizure incidence is 3.5%. This is the commonly asked question. What is the intrapartum seizure incidence? So, it is 3.5%. And fetus epilepticus is less than 2%. Now, what are the factors which contribute to deterioration of this epilepsy during pregnancy? So, poorly controlled epilepsy prior to pregnancy, seizure frequency more than 1 per month, multiple seizure types, drug-resistant epilepsy, the women who are on high-dose polytherapy. Okay, so they are receiving multiple drugs and with that too high doses, poor compliance with antiepileptic drugs, reduced drug concentration in pregnancy due to increased renal clearance and metabolism, and some things related to pregnancy, that is nausea, vomiting, that will also decrease the antiepileptic drug concentration, and sleep deprivation, labor. These are the things which are the triggers for the seizure, like which will cause hypoxia. Okay, so sleep deprivation, labor pains, and hyperventilation. These are also triggers for the seizures. Now, where to postpone or avoid the pregnancy? So, in case of uncontrolled seizures, particularly tonic-clonic seizures, high dose of antiepileptic drugs, polytherapy, that means multiple antiepileptic drugs, drug-resistant or uncontrolled epilepsy, non-compliance with medication, and poor general health with other medical comorbidities. So, these are the conditions where the woman should be advised to avoid or postpone the pregnancy. Now, risk of developing childhood epilepsy in the fetus. So here you have to explain to the woman regarding there is increased risk of epilepsy if her first degree relative has epilepsy. So for the fetus, it is important. The risk is multifactorial and depends upon the type of epilepsy syndrome. And individual genetic susceptibility should be discussed with the patient's neurologist and epileptologist. So there are some genetic syndromes which are associated with the epilepsy. So those you have to rule out any hereditary causes that should be ruled out for epilepsy, which can be transmitted. Now regarding the medication in pregnancy. So 5 milligram folic acid, it should be pre-conceptionally and throughout the pregnancy. So it is very important. It is not in the first 3 months, but it is throughout the pregnancy, and the dose is 5 milligram to reduce the risk of congenital malformation and long-term cognitive effects. Because these anti-epileptic drugs, these are responsible for the effects on the fetus, not only in the first trimester, but throughout the pregnancy. Avoid any abrupt withdrawal of these anti-epileptic drugs. Aim for monotherapy with lowest effective dose. If patient is taking sodium valproate, consider weaning off or alternative with the advice of neurologist or obstetric physician. So gynecologist or obstetrician should not change her medicine on her own, but you have to take a neurologist or her epilepsy doctor opinion. If sodium valproate needs to be continued, change to the moderate release or increase the daily frequency to reduce the risk of high peak levels of the drug. This is very important. Doses more than 800. This was also a question once asked. So doses more than 800 milligram per day, they are associated with greater risk of teratogenicity. So, valproate, if she's taking more than 800 milligram per day, it is also associated with increased risk of the congenital malformations. Avoid using sodium valproate as first-line treatment in any woman with epilepsy of childbearing age unless other treatments are ineffective or not tolerated. And what are the first choice? As I told you, lamotrigine, levetiracetam, and carbamazepine. These are the better choices of childbearing age. But there may be some women with epilepsy for whom the only effective drug is valproate, and in these circumstances benefit outweighs the risk. Okay, so it should be used after careful discussion with the woman. Lamotrigine, levetiracetam, they are recommended as first line agent. With the exception of lamotrigine, levetiracetam, carbamazepine and oxcarbamazepine, the plasma level monitoring is not required unless there is a change in seizure frequency, poor compliance suspected, or there are concerns regarding its toxicity. So these are the only 4 drugs which require this plasma level monitoring. Okay, other drugs don't require any plasma level monitoring. If at all it is required, it is required only for these 4 drugs, that is lamotrigine, levetiracetam, carbamazepine, and oxcarbazepine. Given that the evidence for testing plasma drug level is currently inconclusive, it is reasonable to titrate the drug in response to the clinical symptom and seizure control. So it is not the therapeutic drug monitoring, but you have to decide the drug doses depending upon our clinical symptoms. Now, what are the risks to developing fetus? So usually these anti-epileptic drugs carry low risk. There is increased risk of MCMs. MCM means major congenital malformation due to these anti-epileptic drugs. But as I told you, these 3 drugs, they are safest: lamotrigine, levetiracetam, and carbamazepine. So in this talk, they have multiple times stated that these 3 drugs are safest for use in pregnancy. Sodium valproate, it has the highest risk of this MCM, and there is also evidence of increased risk of cognitive difficulties and learning disability in children of mothers taking sodium valproate during pregnancy. Risk of epilepsy on the fetus. Risk of epilepsy, not drugs, on the fetus. Risk of hypoxia. Okay, can you hear me?
Now we
Yes,
can hear,
now.
ma'am.
Yeah. So 1 minute. Till what time you were able to hear? Which slide? This slide was okay?
This is the slide we are going through.
Okay, no problem. Okay, thank you. So 1 minute. So major congenital malformations, these are associated with anti-epileptic drugs. These are oral clefts, cardiovascular defects, urogenital defects, and neural tube defects. Minor malformation are fetal anticonvulsant syndrome, which include facial dysmorphism, hypertelorism, hypoplasia of nails, digits, and midface, and increased risk of SGA. That means small for gestational age. It is the risk is increased twofold. Increased by twofold when patient is taking anti-epileptic drugs compared to the patient not taking anti-epileptic drugs. So this is the table given in this talk. So here basically what are the important is, so when the patient is not taking any anti-epileptic drug, The risk of congenital malformation is that of the basic population, baseline population who is not on any drugs. So it is around 1 to 3%. Here it is given 2 to 2.3%. So 1 to 3% is the basic risk of congenital malformation. So it is also with women of epilepsy who are not taking any anti-epileptic drugs. Now, when you are comparing the drugs, the highest malformation is associated with valproate. It is 6 to 10% and it is dose dependent. And the malformations associated are neural tube defects, facial clefts, hypospadias. Remember this thing. So hypospadias is associated with sodium valproate and topiramate. Okay. So I think there was one question regarding this hypospadias also. And poor cognition and neurodevelopment. Now the least malformation according to this TOG is associated with levetiracetam and lamotrigine. Now, according to GTG also, the least malformation is associated with levetiracetam. But in GTG, they have added one more sentence that, but the evidence regarding this levetiracetam is not totally conclusive. But for lamotrigine, there are so many studies available. So if you want to go according to GTG, it is the lamotrigine which is associated with the lowest risk of congenital malformation. Yes, percentage is lesser with levetiracetam, but evidence is poor. Okay. And then highest risk is associated with polytherapy with valproate. So there was one question previously. So it is sodium valproate, polytherapy with valproate. So highest risk of congenital malformation is associated when the patient is taking multiple drugs along with this valproate. Okay. And in breastfeeding, there is the only single drug which is needed to be avoided is phenobarbital. Okay. So it should be avoided for the risk of this drowsiness. All other things are almost safe, okay, for the breastfeeding. So I think, am I clear regarding this table? Yes. So now what is this theme? So in case of antenatal care, the woman with epilepsy should be managed with this MDT, that is multidisciplinary team. So which are the people who should be included in this multidisciplinary team? So obstetrician who has a special interest in epilepsy or maternal medicine trained, neurologist with working knowledge of care and management of pregnant women with epilepsy, obstetric physician wherever available, general practitioner, anesthetist, midwife, epilepsy nurse specialist should integrate into routine antenatal service. So this is the flow chart. Now this flow chart is somewhat faulty. Faulty means what they have done is they have integrated these two guidelines. One is RCOG and one is SIGN guideline. Okay, regarding this management of epilepsy in the antenatal period. So you have to take what is related to RCOG and what is the recommendations by SIGN. Those you should not be included in your answers. Okay. So yes, pregnancy with epilepsy. Sorry. So you will be taking a patient will be taking 5 milligram of folic acid throughout the pregnancy. Okay. If the patient is a patient is not on any drugs, she is seizure free for more than 10 years and no anti-epileptic drugs for more than 5 years, she should be managed at low risk. That means she is not having like any epilepsy, but she develops any further seizure, she is again classified as high risk pregnancy. Now high risk pregnancy will be managed by the MDT as I told you. Okay. Individualize the frequency of visit depending upon the severity and stability of the epilepsy. Every visit, you have to involve other specialties like pediatrics, anesthetist, and neuropsychiatrist. You have to explain the woman or advise the woman regarding avoid seizure triggers, ensure the compliance of the drug, assess seizure frequency. Now, this is consider AED levels and titrate dose. This is not recommended by RCOG. Drug monitoring is not required according to RCOG. Even this vitamin K 10 milligram is not recommended by RCOG. So, remember well, you have to, this should not come in your question. Now, whenever ultrasound, so this is most important, growth scan from 28 weeks, okay? Serial growth scans from 28 weeks, but echocardiography is not recommended by RCOG. Routine fetal echo is not recommended by RCOG. Remember this, okay? Now, regarding intrapartum care, as I told you, percentage of intrapartum seizure is 3.5%. Delivery is recommended in consultant-led unit. You have to admit the patient in early stages. Establish IV access and one-to-one midwifery care. IV access is very important, okay? Then adequate analgesia should be maintained. Patient should be well hydrated. She should be compliant with her AEDs throughout the labor. Avoid stress, hyperventilation, and sleep deprivation. So these are all seizure triggers and they should be avoided. Use of methadone should be avoided. This is also important thing. This is also a repeated question because it precipitates the seizure. Okay. And epidural is safe. Epidural is very safe in women with epilepsy. Now, intrapartum seizures, it should be treated with benzodiazepines. So, first choice of drug is lorazepam 2 to 4 milligram IV bolus. Okay, repeated every 10 to 20 minutes. So, first choice of drug for intrapartum seizure, it is lorazepam. Now, if the patient doesn't have IV access, then it is the diazepam suppositories. If the lorazepam is not available, then IV diazepam. So these are the three options. These are available for you. If the patient doesn't have IV access, you have to give diazepam suppositories. Okay. So this is the EMQ. This was the asked in my exam actually for this epilepsy drugs. So intrapartum seizures, they have asked all the three things. One patient was having eclampsia, so there was the drug was Maxel. One patient, she is not having IV access, so it was the diazepam suppositories. And one patient is having intrapartum proper seizure. She is more admitted in consultant led unit. So there the choice was lorazepam. So this was the EMQ which was asked. And if the patient gets seizure, intrapartum seizure, then left lateral tilt, oxygen, and continuous electronic fetal monitoring. In refractory cases of intrapartum seizure, IV phenytoin can be used. The dose of phenytoin is 18 milligram per kg. Loading dose is 18 milligram per kg. Can be increased by 5 milligram per kg to a maximum rate of 50 milligram per minute. Okay. So refractory cases, dose of drug of choice is phenytoin. Yeah. Drugs. Okay. So yes, that recall question was there were three questions in that EMQ. One question was directly she is having hypertension. The BP was mentioned and everything. She doesn't have any history of epilepsy and BP is something like 160, 100 and patient is throwing seizures. So there was this was answer was Maxel. It was straight away Maxel. The second question was patient is just in the midwifery unit and she had seizures, okay, and she doesn't have IV, okay. So that it was diazepam suppositories, okay. When the patient doesn't have IV access for intrapartum seizures, it is diazepam suppositories. And one patient with proper, she is known case of seizures and all things, she is admitted in consultant unit and she is throwing seizures now. So there the drug of choice is lorazepam. And for refractory cases of intrapartum seizures, the drug of choice is phenytoin. Now for postnatal care and breastfeeding. So absolute risk of postnatal seizures is less, but it is higher than that of during pregnancy. Okay. It is why? Because there is increased stress, sleep deprivation, and reduced AD compliance. Because of increased attention to the baby, there will be reduced compliance, sleep deprivation. So all these things and stress. So all these things act as seizure triggers and increased risk of seizures. So whenever it asks, whenever there is increased risk, when is the increased risk of seizures during pregnancy? So it is postpartum. Okay. Any woman taking AD should have an epilepsy review within first month of delivery because it may require reduction in the dose because this pregnancy related changes will be reversed. Breastfeeding is encouraged because as I told you, almost all drugs are safe in breastfeeding except this phenobarbital. But caution is advised in women who are taking polytherapy, phenobarbital or benzodiazepines or in preterm women. Preterm babies where they should be closely monitored. Women with epilepsy and their families, they should be advised regarding the safety measures. Now, this is also important. So, what is the safety measures? So, avoid co-bedding, minimize excessive tiredness, placing the baby in a cot or playpen if mother feels unwell, feeding the baby while sitting on the floor, changing and bathing the baby on the floor, and not bathing the baby alone. So these are the things that if she gets unexpected seizures, then the baby's health should not be compromised. So for that, these are the safety measures that should be taken into care of. Now regarding contraception, all women, they should be counseled regarding the contraception in her postpartum period and avoidance of unplanned pregnancies. So the recommended contraceptions are LNG IUS or Mirena, copper IUDs, DMPA injections, because these are not affected by any enzyme-inducing AIDs. Now the patients who are not on any enzyme-inducing AIDs, they can have these routine hormonal preparations also. Okay. So this is regarding this. And one thing more, it is SUDEP, that is sudden unexpected death in epilepsy in pregnancy. So this is the death which is unrelated to trauma, drowning, or status epilepticus. Okay. So because of seizures, trauma is common, drowning is common, status epilepticus is common. So, but the deaths which are not attributable to all these three causes, but if the patient has the history of epilepsy, then the death is categorized as SUDEP. It is the most common or predominant cause of death in women with epilepsy. So the modifying risk factors like AED compliance, first aid training of family members, and avoiding sleeping alone. It can reduce the risk of the SUDEPs. The incidence of SUDEP in women with epilepsy who are taking lamotrigine, it is more. That is 2.5 per 1,000 patients. While the patients who are not taking lamotrigine or who are taking other drugs, the incidence is 0.5 to 1 per 1,000 years. Now, why it is common? Why they are given the explanation for this lamotrigine, that because a common use of lamotrigine and reduce serum drug levels with advancing gestation. So lamotrigine is a drug basically which has a very low therapeutic what we can call it as a levels, therapeutic safety levels. So here the drugs concentration varies with this gestation age, and then if the concentration is reduced, then seizure frequency will be increased, and it is responsible for the SUDEP. So this is regarding this epilepsy talk. Now there are so many questions on this epilepsy topic itself, but I have taken the only 2 questions which are there in strategy regarding this talk. So for this is the first question, you can answer in your chat box. How does the estimated risk of major congenital malformation in babies born to women with epilepsy, but which are not on any medication, compared to that in non-affected pregnant age-matched population? Yes. So if the patient having epilepsy or patient not having epilepsy, if she is not taking any drug, the risk of congenital malformation is similar in both population. Answer is D. Okay. Even if the patient is having epilepsy and she is not taking drug, it is the similar like the patient who doesn't have epilepsy regarding congenital malformation. So answer is D. When during pregnancy, next question, when during pregnancy does exposure to antiepileptic drug runs the risk of causing harm to fetus? So when these antiepileptic drugs cause harm to the fetus? I have given you the answer while I was discussing the talk. So yes, it is E. It is throughout the pregnancy, because it has, as I told you, it is not only major, correct? It is not only major congenital malformation, but it is the effects like growth restriction, any learning disability, facial dysmorphism. So all these things can occur anytime, okay, or SGA. So it is throughout the pregnancy. Answer is E. So this is regarding the talk. Tomorrow we will have discussion on another talk. By that time, thank you for attending this thing. Bye.
Thank you.